Welcome back to my channel. A blood clot in your lungs can kill you within a minute. That's a pulmonary embolism. But how does it happen? Pulmonary embolism is a sudden obstruction of pulmonary arteries by a thrombus. Let's break down its pathophysiology, clinical presentation and management step by step. The majority of pulmonary emboli arises from the propagation of lower limb deep vein thrombosis. Rare causes include septic emboli from endocarditis affecting the tricuspid or pulmonary valves, tumor, especially choriocarcinoma. Clinical features. The diagnosis of pulmonary embolism may be aided by asking three questions. Is the clinical presentation consistent with pulmonary embolism? Does the patient have risk factor of pulmonary embolism? And are there any alternative diagnoses that can explain the patient presentation? Clinical presentation varies depending on number, size and distribution of emboli and on underlying cardiorespiratory reserve. Depending on this, we can classify it into acute massive pulmonary embolism, acute small or medium pulmonary embolism and chronic pulmonary embolism. Let's start from acute massive pulmonary embolism. Its pathophysiology is major hemodynamic effect, that is decreased cardiac output, acute right heart failure can lead to acute massive pulmonary embolism. Symptoms include faintness or sudden collapse, crushing central chest pain and dyspnea. Signs include major circulatory collapse, that is tachycardia, hypotension, increased jugular venous pressure, RV gallop rhythm, loud P2 and severe cyanosis and decreased urinary output. In this patient, chest X-ray is usually normal but may be subtle oligemia. In ECG, there's RBB is present and S1Q3T3 anterior T wave inversion. ABG is abnormal with decrease in PaO2 and decrease in PaCO2 level and metabolic acidosis. Alternative diagnoses include myocardial infarction, pericardial tamponade and aortic dissection. Next type is acute small or medial pulmonary embolism, which occurs due to occlusion of segmental pulmonary artery which leads to infarction or effusion. The symptoms include pleuritic chest pain, restricted breathing and hemoptysis. The signs include usually tachycardia is there along with pleural rub, raised hemidiaphragm, crackles, effusion and low-grade fever. Chest X-ray shows pleuropulmonary opacities, pleural effusion, linear shadows and raised hemidiaphragm. It shows sinus tachycardia and ABG may be normal or decreased in PaO2 level or decrease in PaCO2 level. Alternative diagnoses include pneumonia, pneumothorax and musculoskeletal chest pain. Chronic pulmonary embolism. In this, the chronic occlusion of pulmonary microvasculature and right heart failure. Symptoms include exertional dyspnea, and late symptoms include the pulmonary hypertension or right heart failure. Early signs may be minimal, but later patient develop signs of right heart failure. Chest X-ray findings include enlarged pulmonary artery trunk, enlarged heart, prominent right ventricle, and ECG shows IV hypertrophy and strain. ABG maybe shows exertional decreased PaO2 level or desaturated on formal exercise testing. Alternative diagnoses include other causes of pulmonary hypertension. Other key diagnostic, that is investigation to evaluate pulmonary embolism, is an elevated D-dimer test, as it is of limited value as it may be raised in variety of other conditions including myocardial infarction, pneumonia and sepsis. CP is a first-line diagnostic test. It has the advantages of visualizing the distribution and extent of emboli or highlighting an alternative diagnosis such as consolidation, pneumothorax or aortic dissection. Of pulmonary embolism. Sufficient oxygen should be given to hypoxic patient to maintain arterial oxygen saturation above 90%. Circulatory shock should be treated with intravenous fluid or plasma expander. In this patient, diuretic and vasodilator should be avoided as they will reduce the cardiac output. Opiates may be necessary to relieve pain and distress but should be used with caution in hypotensive patient. Anticoagulation. The main principle of treatment of pulmonary embolism is anticoagulation, which we will discuss in next video for pulmonary embolism and other forms of VTE. Thrombolysis is indicated in any patient presenting with acute massive pulmonary embolism associated by cardiogenic shock. In this absence of shock, the benefits are less clear, but thrombolysis may be considered in those presenting with right ventricular dilation and hypokinesis or severe hypoxia. Patient must be screened carefully for hemorrhagic risk as there is high risk of intracranial hemorrhage. Surgical pulmonary embolectomy may be considered in selected patients but carries a high mortality. Caval filters. A patient in whom anticoagulation is contraindicated who has suffered a massive hemorrhage on anticoagulation or recurrent VTE despite of anticoagulation should be considered for an inferior venous caval filter. The caval filter should be used only until anticoagulation can be safely initiated, at which time the filter should be removed if possible. Pulmonary embolism has been occurred in pregnancy. The venous thromboembolism is the leading direct cause in UK. CT pulmonary angiography may be performed safely. It is important to consider the risk of radiation to breast tissue, particularly if there is familiar history of breast carcinoma. Pulmonary embolism in pregnancy should be treated with low molecular weight heparin and monitor patient closely. So that's all about pulmonary embolism. Thanks for watching. If you found this helpful, hit like, subscribe and share because the more people know about pulmonary embolism, the more lives we can save.